So excellent. We are going to have a very interesting debate. And the title precisely is Greening Critical Care. Can we do it? Now, I didn't find any more precious prize than this special pin with the cappuccino with Claudio Ronco, but the winner will get this. And you will decide at the end who is going to be the winner. So we will have a vote at the end. And we start with Professor Jean-Louis Vincent on the yes side. You have 8 minutes because we want to have a little rebuttal possibly afterwards.
Very good. Yeah, okay. But, you know, we are all convinced that this is very important. So I don't see the point. Obviously, we have to do something for our planet. And it's not only in the hospital, it's around it. If we think about it, patient transfer, hospital staff commute, visitor travel, it already consumes some energy and produces CO2. Maybe we should have more green cars. Maybe we should take our bicycle. In some hospitals now, I believe in the Netherlands in particular, you cannot have a spot in the parking lot if you live nearby the hospital. You need to take your bike. Okay, within the institution, of course, we must be careful to try to limit the use of electricity, warming, cooling, water, and if an instrument is in the sleeping mode, we could perhaps try to even further limit the electricity demand of the instrument. But there is a lot to say about the pharmaceuticals, the medical equipment, monitoring, diagnostics, and even food services. And for any component of the system, we need to think in terms of life cycle assessment, going from the material acquisition and production to use to disposal through use and recycling. And people who are experts in the field, and I am certainly not, could tell you that, for instance, 1 milligram of morphine generates 2 grams of CO2 emission, okay? And you can do it for everything you use. Try to avoid paper. Of course, paper belongs to the past. And this is an interesting study from Mrs. Hunfeld, who is a pharmacist in the Netherlands, very interested in these aspects. She will give a talk at our opening session in 3 days in Brussels. She actually looked at one single patient at all the things we consume, starting with disposable gloves and compresses and liquid, basically intravenous fluid bottles, etc. I think that's a very interesting exercise. We should try to do it from time to time, and that could help us to identify the elements that could perhaps be controlled. And she also looked at packaging, because it's not just the substance itself, it's the package that could indeed produce quite a bit of CO2, again, from the very beginning until the very end. This is another recent study just published showing that consumables are a big part of the problem. And plastic, of course, is at the top of the list. Most plastic are made from fossil fuels, and their manufacture produces huge volumes of greenhouse things. So waste is, of course, the next item. What do we do with the things we no longer use? We should try perhaps to recycle what we can recycle. But in terms of waste, our contribution is relatively small in proportion to the overall carbon footprint, but it's one that is actionable at the individual level daily. There are quite a bit of studies in the operating room where they need to prepare their tray for a surgery, and I have no time to discuss all this, but it's interesting to see how people could gain in thinking more at what they need during surgery. You could even here compare different modes of anesthesia and actually put together the consequences. So there are several choices. We can reduce single-use plastics, reduce oxygen flows, collaborating with engineers to augment energy efficiency, renewable electricity. When I was a young doctor, you know, in Brussels, we were reusing the Swan-Ganz catheters because it was very costly. And then, of course, we said, no, we shouldn't do that. We should take a new one each time. But now we can think about it and perhaps consider reusing the few Swan-Ganz catheters we still use. Pressure transducers. Remember? Maybe yes, maybe no, depending on your age. But I remember very well the discussions we had in our department when people said, you need single-use transducers, much better, you throw it away. We may actually perhaps come back to the reusable. Likewise, the blood pressure monitors, you know, the reusable blood pressure cuff are environmentally preferable in terms of greenhouse gas emissions and other impact, in some cases by a factor of 40. Laryngoscope. The industry came and said, okay, why don't you use single-use laryngoscope? And indeed, we went for that. But perhaps we shouldn't. When I was young, we had reusable gowns for patients who may be isolated for resistant organisms. And again, I remember all the discussions we had to go for single-use gowns. We may go back. Who knows? We need to think about it and discuss it. This is, I think, a very interesting recent analysis where they looked at reusable metal items and reusable textiles at the top. At the middle, reusable metal items and single-use textiles. And at the bottom, single-use metal and plastic items and single-use textiles. And you can see the huge differences in CO2 equivalent production. So again, throwing away every single thing we use may not be the best idea. So this is our ICU. It suggests we can do quite a bit to try to decrease the CO2 equivalent production, including perhaps using less disposable gowns, and certainly try to use less disposable gloves. We use gloves to limit the transmission of microorganisms and or to protect our hands, but we need to think about the fact that this could be bad for the patient. So now there are campaigns to take your gloves off, not to use gloves too routinely. Look at this type of poster, how to reduce glove use. And we need to remind people that indeed there are indications for gloves, but there are also, as reminded by the WHO, there are also non-indications. And so people should know when they should use it and when they should not. In the UK, there have been quite a few excellent campaigns to take your gloves off. And here in the Children's Hospital in London, you can see that they decided to use less gloves and they measured their consumption. That's also something we could do to try to limit our impact on this. You can see that the nurse holds the patient's hands. And that's something I am very concerned about. I love to speak about how to make rounds and how avoiding to have crossed arms, but I have crossed arms myself on the picture, so that's not how we should be in the presence of a patient. We should not hesitate to touch the patient, and of course, we should wash our hands thereafter. We should not touch the patient with gloves. So getting the staff engaged, I still have 1 minute and 17 seconds. We all need to look at it and try to improve our world. And so, yes, priorities, number 1, number 2, number 3. There are lots of things to be done for a green ICU. Some of these schemes are relatively complex. With some colleagues in Houston, we just submitted this paper for publication referring to a culture for green thinking, proposing as a step 1 to conduct life cycle assessment of ICU products and processes, as a step 2 to develop green ICU intervention through strategic partnerships, and step 3, create green ICU teams comprised of ICU staff. So we need to have people who are particularly concerned to sit together and to analyze what we could do. So this is recycle time, reduce team, sorry, I'm going so fast. Recycle team, reduce team, and rethink team. Of course, this should be done not only within our staffs, but with people around it and people in our institution and perhaps healthcare deciders. It's a real team effort. It's not one person that should do it. We should do it all together. And we need to motivate our people around us. Thank you.
Thank you very much. You actually use not only your 8 minutes, but the 10 minutes, so you will have no right to rebuttal in the future. But let's have now Marlies staying on the maybe side.
Thank you very much to Ravi and the organizers for inviting me. And I think this is a very important topic, and I'm pleased it's in the program, because climate change is real, global warming is real, and it's very clear that hospitals and healthcare make a major contribution worldwide. And within hospitals and within healthcare, it's the intensive care unit which makes the biggest contribution for all the reasons which Professor Vincent explained. Now, I am very keen to promote a more sustainable ICU. And we've just heard of all the possibilities from Professor Vincent. And I just show you a few things where I think things can be done, but at the same time, I show you where I struggled and essentially failed when I tried to do it in our ICU. So this is a picture which was not taken in the ICU where I work, but it could have been taken. And if you have a picture like this, you can immediately think this is a golden opportunity to reduce waste. And if you reduce waste, you reduce CO2 emission. So that was easy to deal with in our intensive care unit. But then we also looked at other publications and other options, and we, again, like Professor Vincent, were very impressed by Nicole Hohenfeld's paper, where she essentially had people parked at the bedside, and they counted one by one what was being used by healthcare professionals at the bedside. And they identified these key areas, so gloves, gowns, and plastic. And like Nicole and others in the UK, we then also tried to reduce this. And we've reduced the glove use a little bit, as it's a big campaign in the UK. But then it came to other things, like reducing the packaging. And clearly, there's nothing we can do about this. The boxes arrive, and they fill the shelves, and there's nothing we can do. All we can do is try to reduce the consumption and use less. But one of the things which takes up a lot of space on our shelves are the renal replacement therapy fluids. We use a lot in our ICU, and they fill shelves, plenty of shelves. And the question is there any chance we could reduce this? Because if you do a life cycle assessment of RRT fluid, it turns out that they actually make a huge contribution to the CO2 emission for the reasons as displayed here. You use material, the fluid doesn't get produced locally, it gets produced somewhere in Europe, it has to come to the UK where I practice, by ferry, by lorries. All of these processes produce a huge amount of CO2. And then obviously it has to be disposed of. Now, could we do something different? Well, we can, because I know from our own experience that we can make renal replacement therapy locally, the fluid. We had to do this during the COVID crisis, where my colleagues in the pharmacy department produced dialysis fluid because we had completely run out. There were no lorries coming from from Europe mainland. And so we can do it. So my question to the team was, let's do it again to reduce the CO2 consumption. And when we looked into this, actually, it turns out it will be more expensive for the department and it will create more work for the team. And as a result of this, we're continuing to buy fluid from commercial companies which come to us by lorry. So this project failed. The next question was, can we reduce our phlebotomy and reduce the number of blood tests? And the reason we wanted to look into this, because we came across this paper here from Australia, where the team essentially looked at the, again, did a life cycle assessment of blood tests. And again, starting with the fact that to do a blood test, you need a tube, and you need a syringe, and then you need some gloves, and they have to be produced somewhere, and you need raw material, and then they get shipped to the department by lorry. All of this produces CO2. And here we have the CO2 production of the various blood tests. If you compare this with the CO2 production created by cars, driving a car, then you can see it's terrifying. So the question was, is there any chance we can reduce our blood tests? That's to contribute to the environmental sustainability of the department. And essentially, when we discussed this within the team, there was huge anxiety. People were concerned that if we didn't do these blood tests, we may not make the diagnosis on time, we may create harm, we may not diagnose hidden problems, and people may be accountable and be taken to court. So far, we've not been able to reduce the amount of blood tests. And now my third project. This is a really nice figure, which essentially gives you all the areas where you may think and have options and opportunities to reduce CO2 emission. So reducing, recycling, reusing. So one of the things here was recycling. And as Professor Vincent already said, we in the past used a lot of materials and kits that were reused and recycled, but we now use single-use kits, scopes, tools. And one of the single-use tools or devices which has gradually crept into our use were single-use bronchoscopes compared to reusable scopes. Now, they work. We like them. And they have lots of advantages because we just quickly take them. They don't take long to set up, and we dispose them. And then it's the end of the story. In contrast, the scopes, which have to be recycled, take longer to set up. They have to be taken to a place where they get sterilized. They spend 24 hours outside the ICU. They get damaged, we lose them, and then there are times when suddenly there's no scope in the department because it's just being sterilized. Having discussed it again with my colleagues, whether we could stop using single-use scopes, I failed because my colleagues prefer, for various reasons, these scopes. Our finance colleagues prefer them because the costs for sterilizing and replacing damaged and lost scopes was higher than buying single-use scopes. So we still use them. And here we are. I like the whole idea. I really have bought into this. I think it is important. I think we have responsibility. But in real life, it is a challenge. I rest my case.
Thank you, Marlies. And thank you for staying in the time, even gaining some minutes, seconds. And now Derek Angus will have probably a different perspective.
Of course I don't have a different perspective. My main perspective is that I was totally sandbagged by Ravi, by asked to actually defend that we should just drive this planet off the cliff. So I'm not going to defend it. So I'm here to say, do not dare vote for me at the end of this. I just decided to try to wrap this up a little bit by asking, first of all, do we need to green our ICU? Yes. Why? As we've already heard, US healthcare produces 8% of the country's carbon footprint. That is almost 500 million metric tons of CO2. Why is this important? We do this with no criticism. There's no adverse publicity about healthcare chewing through this huge carbon footprint. All the negative publicity goes to smoke-belching factories and gas-guzzling automobiles. And so it's very important to not only know it's a big number, but it's a silent big number. The next thing is that among the entire healthcare consumption, it's hospitals and ICUs that are the largest contributors. And it's not just because of the physical plant. It is actually about these care processes. So what you were hearing today about sort of the bags we use, it's the things we're doing in the ICU. It's not the structure, it's the process. No one's saying that you need to run the ICU with the heat turned off, although it would help, or with sort of, low emission LED lighting. That would all help. But the main issue is how we're actually spending our different days. So how can we reduce the ICU carbon footprint? Now here's one of the points I wanted to make. In the US, I'm just here to guarantee it will not be Washington that drives this. We cannot, even when there's adverse publicity, the corresponding lobbies stop it happening. This isn't even raised as an issue in the US. Every single paper they published, they cited in their talks, were from outside the US. There was one overview paper in the New England, but there's no primary research going on this topic in the US. So it's not going to be our government who's going to fix this for us. It's also not going to be our healthcare leadership. We have appointed a sustainability officer at UPMC Health System. I don't think he's getting paid for it. He's not done any grand round talks anywhere. It's just not on anyone's agenda. And our healthcare system CEOs are mainly just trying to keep the systems afloat after a lot of the post-COVID rebates and so forth through Medicare and Medicaid have run out. There's no top-down support for doing this. It requires grassroots activism and individual action. So the title of this session was, Can We Do It? And I'm going to start by saying, who do you think is we? Because we is not Washington, D.C., and we is not our healthcare leaders unless we tell them so through grassroots activism. Unless your politicians go to Congress and say, I got elected to mandate new legislation for greener healthcare delivery, it's not going to come down from the top. So our actions are absolutely lobbying. And then in addition to things you've already heard, green health centers, green teams, green prescriptions, education, and raising awareness. Raising awareness among our own colleagues. So Ravi, thank you very much for having this session. No, I'm not at all happy about defending the no position, but I love that this is titled a special lecture. And so I want to close with just sort of two quotes. So there's a beautiful overview that was published relatively recently in the Journal of Law, Medicine and Ethics, and this is very much about the US. While there is justified suspicion about American healthcare, really? Which is capitalistic and automatized or atomized, as in it's all split up and there's no universal healthcare. The potential for individuals, all of you in this room, to change the system is also its greatest strength. Historically, healthcare policymakers have been amenable to stakeholder requests. That obviously happened with the HIV lobby, for example. And many patients and physicians recognize that a healthy body and mind depend on a healthy planet. Their collective actions, our collective actions, can stimulate green healthcare reform. So you would only vote for me about can we do it if you first of all understood we is us. And you secondly understood that you would not rise to this challenge. It is up to us. Adam Weishaupt, by the way, complicated character. He was the founder of the Illuminati. But this phrase is what I'll end with. It is up to us. No one is coming to help us. If we don't make the effort, no one else will. And with that, thanks.
So we still have a couple of minutes. I hope, Ravi, you don't mind. We just started a little bit later. We heard from Professor Vincent what can be done or should be done. We have heard from Marlies that sometimes the attempts are good, but not always. Intentions is good, but not always we can reach our outcomes. And we heard, I think, from Derek, that we need to be proactive. We cannot expect somebody to take this position and help us in presence of governments and other institutions that are not really receiving any incentive, or they are not really have any initiative for this. So may I ask, in spite of your using all your time, to comment on the Marlies attempts, because you mentioned some things can be done. Marlies showed that it's not so easy. So how can we practically approach this problem being less emotional, less political, and more pragmatic?
Well, I think we can do much, but that's by speaking up. And indeed, if we just whisper, yeah, that's important, but I don't know what to do, I'm waiting for the politicians. No, the politicians, they do what their electors want them to do. So if there is indeed a movement that can really convince them that many people are concerned about this, they will definitely move. So it will take time, of course. It's not in one day that we will solve all the problems. I think we need to go step by step. And what we tried, Marlies and I, to show you in the presentations is that we can already now, in our ICUs, raise some important questions. What about the disposable fibroscope? What about this disposable material, etc.? So, and that's a team approach. Again, it should not be limited to the ICU. Okay. It should go beyond that. And so we need to sit down together with the pharmacist, with the hygiene people, with the physiotherapist, and of course with the hospital management. And really say we will do something. I am impressed by the movement in the Netherlands. To me, it's really, and in the UK for some elements. But people in Europe, as you said, people start to move in that direction. And I'm pretty sure that in the US too, it will move in that direction. Just about Marlies, one thing she said, packaging, we don't know what we can do about it. If it comes with that packaging, okay, we buy it as it is, and that's it. It's beyond our control. I do not entirely agree, because we are here to discuss with the industry. We are here to try to make them change their strategies to try to limit the CO2 production. Okay. So I think we can do something about it. Yes. Okay. Not only in the ICU, but much beyond.
Yes, and I take the privilege of being the moderator, just reminding that, however, we should maintain the rigorous approach of science to what we do, because, for example, we have now almost 1 million of people around the world doing chronic dialysis, and every week they have 3 dialyzers. In the past, in US, reuse of dialyzers was a common practice. And when they stopped reusing, the mortality rate decreased significantly. Sure. So we have to be careful not to kill people with the intention not to kill the planet.
Of course. That's obvious.
In general, at this point, the positions were not so different, but we still would like to have your vote. So who's going to vote for Professor Vincent? Raise your hand. Oh, you didn't convince too many people. Who's going to vote for Marlies' point of view? Oh, okay. And who's going to vote for Derek? Okay, I basically take that you're all agreeing that something can be done, should be done, but this goes to Marlies.
Thank you.
So the point is, something should be done. We have to try step by step to move forward. But also, I agree with the other 2 speakers. We need to do personally something. Otherwise, nobody's going to move on our behalf. Yeah. Thank you very much.
Thank you. Thank you for the